Before we get started today, I'd just like to let our audience know of a way to support our podcast. Our team is committed to providing free, high-quality, unbiased content to our listeners. We currently do not take any funding from industry sponsors or advertising, and we hope to keep it that way. So if you want to help us keep bringing you great content, go to audiblebleeding.com/support and find out how. We'll put a link in our show notes. And now, on with the show.
This is Audible Bleeding, the vascular surgery podcast. We're here to help you keep your finger on the pulse.
All right, welcome back to Audible Bleeding. I'm Edhem El-Mosley, and today Matt Smith and I, along with Dr. Lozzi, are excited to sit down with Dr. James LittleJohn for a special episode of Audible Bleeding to discuss the ICU management of COVID-19 patients. In our hospital already, there's several surgeons and physicians in general who are being redeployed to the ICU to help manage patients with COVID, and in the coming weeks, there'll be even more. So this is a real issue. There are people who are comfortable with doing this, who have some critical care experience, and there are some physicians who are rightfully somewhat concerned that they haven't managed ventilators and drips and proning and heart failure, et cetera, for a long time. There are some guidelines, whether they're released by our hospital or COVID-specific literature curated areas or the Surviving Sepsis COVID panel, that are helpful. But I think the goal from this specific episode will be to sit down with an expert in critical care, in this case, Dr. LittleJohn, and help create an audio primer for those of us who are going to be redeployed in the ICU. Dr. LittleJohn is a board-certified anesthesiologist and critical care doctor who practices at Weill Cornell. He completed his anesthesia residency at Cornell and then went on to fellowship in surgical critical care at Penn. After that, he went to UC Davis to practice as a critical care anesthesiologist and a SICU attending for a few years, finally moving back to New York City to work at Weill Cornell as a cardiothoracic surgical intensivist and anesthesiologist who specializes in ECMO, liver transplant, and complex anesthesiology. Dr. LittleJohn, thank you very much for joining us.
Thank you. It's a pleasure to be with you.
So getting started, I want everybody to keep in mind that the data on all this is very limited and evolving. We're going to try not to get too much into the weeds, but talk about practical points that everyone can use when they're taking care of these patients. So getting started off, you're walking into a room and the patient's suspected of having COVID, and you're being told they're hypoxic. Before you enter the room, what are some of the important epidemiological things you have to know and things about how the virus itself is transmitted with regards to aerosolization and how it interacts with fomites to think about before you actually place the PPE on and go into the room? And what's the PPE that we should be wearing?
That's a great question and sort of broad. I'll start with my approach and my concerns. There has been wide variability in the media, both the science and media, about the transmission and the survivability of these virions in the world. That will continue to evolve, some of which is due to the fact that we've just never truly studied virion survivability in this way, or it's never been such a hot topic. My approach, and I have some experience having done some research in other truly airborne pathogens, is that sometimes the nomenclature as it's delivered, we're not as precise as we should be. This virion is not truly airborne the way other weaponizable pathogens can be weaponized and made airborne. With that said, it is aerosolized. Those aerosol particles, depending on their size, can be projected and or exist in the air or in the environment, the fomites you mentioned, for a variable amount of time. So without getting into the weeds, as a practitioner, when I walk into the room, I assume every surface has COVID present. I assume the breath coming out of my patient has COVID there, and I assume the air in that room has COVID, and I protect myself accordingly. It's important to note that ideally these patients are in negative pressure rooms. What does negative pressure mean? Negative pressure does not protect the patient or the people in that room from breathing in or touching COVID. What it does is it protects the outside environment. When a door is opened, air does not rush out of that room, it rushes into the room. So negative pressure rooms keep anything that's aerosolized from leaving that room. It doesn't protect the people standing in that room. What do I put on? So I work in scrubs, and I make sure that anything that's exposed to air are things that I can change, wash, sterilize, or throw away. That's how I walk through my hospital, to be quite frank. because the fact that COVID-19 is so prevalent in society means the likelihood of anybody in this hospital where COVID is highly prevalent is higher. So I just assume even walking through the hospital, I wear at least a surgical mask, as well as a cloth cap, surgical scrubs, glasses and or eye protection in general. And then when I'm actually close and or treating a COVID patient, I put on a permeable gown and I wear an N95 mask when I enter the room or I'm within 6 feet of a person with known or high risk of having COVID. I wear a cloth surgical scrub cap at all times while at work, and I put on a bouffant over that. I'm not sure if the bouffant actually helps or not, because ultimately the cloth cap I wash or sterilize at the end of every shift. So that's my approach in terms of entering the room with a COVID patient who has an unprotected airway.
Dr. LittleJohn, can you give us a brief synopsis of what the general phenotype of these ICU COVID patients looks like?
Yes, I can. We don't have a precise idea of what the mild or indetectable disease looks like out in the general population. So I won't speak specifically to that. But the disease we see in the hospital, and that's been classified, I generally believe the number is roughly 20% at the moment of the COVID disease that we identify in the general population is in need of hospitalization, and roughly 5% or less is in need of critical care. Those patients present generally with dyspnea and hypoxia. There are other symptoms that they may or may not complain about and other signs that you will notice. But the signs typically are respiratory distress. Sometimes the sign is really only hypoxia alone. It's very interesting. These patients generally don't even feel that bad, but they're profoundly hypoxic. They require 6 liters nasal cannula oxygen to keep their saturation above 88. And otherwise could be a normal, healthy appearing person right in front of you with hypoxia alone. Generally, the more of these we see, you develop an understanding, these guys look like they probably have COVID. You wouldn't honestly be wrong if you walk through an ED right now, because the odds of a patient in the ED having COVID in New York City is almost 100% right now. Anecdotally, it's described as having a roughly mild viral prodrome for potentially a week, a mild fever, sore throat, maybe dry cough, sometimes even getting better. Usually they'll present early on to the hospital, and we're seeing that these folks who have mild or moderate disease are being sent home, A, because there just aren't enough hospital beds, and B, it really is reasonable to monitor these folks with mild symptoms at home unless they decompensate. And what we're seeing, the ones who decompensate are coming back in. When they are coming back in, they're profoundly dyspneic and or profoundly hypoxic. At that point is when I generally see these folks being a critical care physician. The system we have at our institution is now we have so many skilled practitioners. We all are sort of specializing in our roles. So I, as an intensivist, generally live in the ICU right now. The airway team and the MICU outreach team are generally the people who are consulted by the ED. It wasn't always that way. So when as we were developing this system, you would see somebody in the ED and you would have to ask yourself, well, what modality of oxygenation should I have to put them in? So on 6 liters nasal cannula, if they're still in respiratory distress, then you have to ask yourself if they need higher amounts of oxygenation with a non-invasive modality, or if you actually have to intubate them. Once you intubate them, you set off a whole nother series of pathology and instances where the ventilator management alone could really create part of this phenotype that we're actually seeing. It's difficult to know how much is due to the virus or how much is due to the treatment that we need to maintain oxygenation. But initially, the phenotype of moderate to severe COVID-19 is described as profound hypoxic respiratory failure.
Jim, can I ask a question? What are you using as your criteria to intubate in these patients? Are you looking only at oxygen saturation? Are you looking at ABG? And do you see any role for the use of CPAP or other positive pressures in these patients?
The decision to intubate is a complex decision. Anecdotally, there's not a lot of good systematic data to support this, but we notice that when a patient does present in this moderate to severe representation or initial presentation of COVID-19 pneumonia, we have to be mindful that when these patients decompensate further, they can decompensate rapidly, more rapidly than other folks who present with impending respiratory failure. What does rapidly mean? Generally, we describe it as within an hour. They can present on 2 liters, mildly dyspneic, and then within a single hour, we've seen them go to 6 liters and non-rebreather, and their oxygen saturations plummet. It can be corroborated with an arterial measurement of oxygen saturation, the PaO2, but in my opinion, it's not even necessary in terms of making the determination. If the pulse waveform is reading 40%, and admittedly, these spectrums aren't designed to read something that low, and your patient in front of you is hypoxic, even if they're talking to you, that would be enough for me to highly recommend intubation. What I have seen, and hopefully in the future it will be shown to be true, is we do believe that early and aggressive intubation in these folks who are decompensating really will help to improve their mortality and morbidity. That is to say, if we wait too long, and it does take a long time to put on the appropriate PPE to intubate these folks, if we wait too long while they're profoundly decompensating, you may inadvertently cause other damage due to this hypoxemia while you're working to intubate and get the oxygen levels back up. So me personally, anytime I walk in to evaluate a patient who doesn't have a breathing tube, if they are dyspneic, already on 6 liters, then I start the conversation already. Because if you're not intubatable now, you may be within the hour. I cannot predict, but you better start thinking about whether or not you would like a breathing tube. Quite often, as I'm at work, I hear cardiac arrest called on the step-down units and the hospital units. Right now, my hospital is next to full with COVID patients and their moderate disease, being treated supportively and waiting for them to get better. At any moment, any one of them are at risk of rapidly decompensating. Given their comorbidities, if they rapidly decompensate before we can even come and reevaluate, I strongly suspect that's one of the big mechanisms of their cardiac arrest or rapid decompensation. So I encourage early intubation. Anecdotally, I've seen that it allows me to stabilize them earlier, and I believe it probably will be found to have an impact on morbidity and mortality. But so to get to the actual answer, I use my gestalt.
And for those of us who may not have your experience or gestalt, it seems like a target or endpoint of 90% on 6 liters. If that's where you are, then generally should be thinking about intubation as the next step. Once the patient is intubated, can you talk a little bit about the initial ventilator settings that we should think about, as well as the endpoints or goals of ventilation?
Yes, once they're intubated, they move into sort of the severe form of COVID-19 pneumonia. And that phenotype is best described as severe hypoxic respiratory failure, and usually actually ARDS. So we apply essentially the ARDS-NET pathway or tenets of the ARDS-NET studies, which I'll briefly summarize. But generally, we accept that this is primarily a single organ issue, primarily the lungs, primarily hypoxic respiratory failure with preserved lung compliance. So our vent management is approached from there. So my initial setting, broadly applied, because sometimes we have as many as 10 admissions a night, is full ventilatory support, assist control. I set the tidal volumes at 6 to 8 cc's per kilogram due to ideal body weight. I set the initial respiratory rate of 16 to 20. We aim for low tidal volume ventilation and high PEEP. What does high PEEP mean? If it's a normal 70 kilo person, I start at 10. And if it's an obese patient, I start at 12. Once you initially intubate them and stabilize them, if their pulse oximeter is reading 88% or lower, I will go up on my PEEP until I can stabilize their pulse oximeter around 88%, and I can draw my first gas. So those are my initial ventilator settings. Start at an FiO2 of 100 until you stabilize the patient. Once you have the ability to draw an ABG, then you work to titrate your minute ventilation, that is your respiratory rate, because your tidal volume is already fixed at 6 to 8 cc's per kilogram ideal body weight. So you would adjust your minute ventilation to make your PaCO2 as such to keep your pH 7.25 or above. We do adhere to this idea of permissive hypercapnia. So as long as the pH is 7.25 or above, we accept a minute ventilation that gives you a PaCO2, something that will give you that. PaCO2s that are typical to see on your first ABG, 50 to 60. As long as the pH is above 7.25, that's acceptable. Primarily, this is an issue of oxygenation. So really, it's your pulse oximeter, your saturation, as well as your PaO2. So we set PaO2 limits. If it's greater than 55 on your ABG, then that is satisfactory. If it is less than 65, consider increasing your FiO2 or your PEEP. These patients are generally very PEEP responsive. This is a condition that is described as having a high shunt fraction. Without getting into too many details, just know that this condition is much more responsive to increasing your PEEP than increasing your FiO2. So once you stabilize them with a high PEEP threshold, high PEEP, that is to say PEEP between 10 and 16 or 18, which I know is PEEP that is much higher than I as a surgical intensivist are used to using. But without that PEEP, you will not rescue their oxygenation. And once you maintain that PEEP, I would leave them there for at least a week. Now, we all know that having those high PEEPs have other physiologic implications that we can discuss later. But sometimes you need these high, exquisitely high mean airway pressures to recruit the parts of the lungs in order to keep these patients oxygenated. So to summarize, initial settings are a respiratory rate of 16 to 20, tidal volume, assist control, volume control, 6 to 8 cc's per kilogram, ideal body weight. Titrate to keep your pulse oximeter above 88% and your PaO2 above 55.
That's great, Dr. LittleJohn. Can you also talk about some of the rescue techniques if you're having trouble oxygenating these patients appropriately, proning, paralysis, etc.?
Yes. So if you adhere to that initial approach, if you give yourself a couple of hours, a lot of times these patients with this severe ARDS, they take a long time to quote unquote stabilize. They may be hemodynamically unstable because of their comorbidities, because of other issues, or because of your vent management alone. So give yourself a couple of hours to really truly ask yourself if your high bean airway pressure, if your high PEEP scenario is actually working. But if for whatever reason their sats are still in the toilet below 85% initially, despite them being perfectly deeply sedated, despite them being perfectly synchronous with the vent, then I would paralyze them first. Mostly because in your initial evaluation, it takes a good amount of time, at least an hour or two, to transport them from the ED to the ICU, to admit them to the ICU safely, to put in a central line and an ART line to actually draw these labs. So in the meantime, if my SAT's not above 88, I have a very low threshold, A, to be very heavy-handed with my sedation, and B, to initially use neuromuscular blocking agents to, quote-unquote, temporarily paralyze a patient to help remove any abdominal tone, any thoracic tone, and any potential for the patient involvement in the ventilation settings. I have a very low threshold to paralyze a patient. If after a couple hours, we're still not meeting our determinants of a PaO2 of 55 and a saturation above 88, then the next step I consider is whether this patient is a candidate for pronation. Pronation definitely is a modality that has its own risks, but has been shown from the ProSiva trial in 2012 that if aptly applied to the right patient, proning a patient for 12 to 24 hours, we sort of hedge and we do 16 hours, which is what the ProSiva trial generally recommends, has been shown to increase a patient's arterial oxygen saturation. Whether or not it has mortality benefits in this phenotype has yet to be determined, but the folks in the ProSiva trial believed it had a mortality benefit in their phenotype, which was severe ARDS broadly applied. So pronation is definitely considered if in 24 hours we cannot meet the determinants that I stated. I advocate for doing what you're good at. So if there are other vent modes that you're good at beyond these basic rules that I've set forth, then do it. Whatever helps you achieve a PaO2 above 55 and a saturation below 88, employ it. Some people are facile with airway pressure release ventilation, APRV, and a very technical and complex vent mode. But if you know how to use it and you know how to use it aptly, you could probably rescue a patient from the need of pronation. If pronation is not an option or you're not able to do it for whatever reason, I also consider the administration empirically of pulmonary vasodilators. We'll keep it very simple and just focus on the prototypical one we're used to using at my institution, which is inhaled nitric oxide. There are other pulmonary vasodilators that you could consider using, but due to the risks of aerosolization and how to deliver it, the safest one at our institution is inhaled nitric oxide. If they're profoundly hypoxic and they're paralyzed and it's the middle of the night and I deem it too dangerous to prone a patient, I will empirically administer inhaled nitric oxide at 20 parts per million to see if I could potentially rescue any occult intrapulmonary shunt and improve their oxygenation. Whatever modality, whatever rescue modality we consider, all I care about is getting my PaO2 above 55 and my saturation above 88 or somewhere close to that while this patient stabilizes. We've found that once you stabilize a patient, then they're pretty good. It just takes a while to get them to sort of whatever management where they will plateau and stabilize with those two determinants. The final rescue modality worth discussing would be veno-venous ECMO, extracorporeal membrane oxygenation. That is definitely a controversial topic in this COVID-19 ARDS, but something that has been applied to many patients throughout the world and some within the city of New York. So it's worth considering. We will consider it at our institution as well on a case-by-case basis. But that is if all the other modalities have failed and or we believe that the patient would exquisitely benefit from ECMO. I can't give you any standards on that, but that would be sort of the final last-ditch effort to try to maintain oxygenation if the lungs simply aren't able to do it.
That was an excellent overview. My one question about proning, for some reason as a surgical resident now 7 years into training, I've actually never proned a patient and was surprised by some of the randomized data that showed the mortality benefit. You spoke a little bit about it already, but what are some of the contraindications to proning people? Because, I've had patients where you just roll them onto their side and they arrest. Is that something you consider when proning? And how do you actually prone a patient when you don't have a prone bed? And what is the specific proning protocol that you use?
Those are great questions. And to be quite frank, up until this point, we didn't really have a specific proning protocol. It was so rarely applied to our patients because somebody in true, profound, severe ARDS is quite frankly rare nowadays. It's something seen in the medical ICU. And usually we can rescue them with our expert ventilatory techniques with paralysis based on the guidelines that were present sort of before this point. Now, I, as well, haven't really proned a patient since I left my surgical ICU, my trauma ICU at UC Davis, because I practice in the cardiothoracic surgical ICU. So to answer your specific questions, there are some very, very real and obvious contraindications to pronation. Being surgical intensivists and surgeons, an open abdomen would be one of them, or a fresh sternotomy. Right, any pressure you put on a wound that could potentially open will predispose the wounds to not healing well. So I've never proned a patient here in my current job either. But with that said, my ICU is now full with medical ICU patients. So getting to your other sort of anecdotal observation is anytime you look at this patient wrong, they could go into cardiac arrest, and that is true. If you wait too long, and a patient is so hemodynamically labile and so delicate that anytime you do anything to the patient, they actually could go into cardiac arrest. So we do try to put some sort of limit on when we would consider pronating these people. Within the first 28 to 24 hours, generally speaking, their vitals, their hypoxia, their gases look fairly bad. Their numbers look fairly bad, but they're not, generally speaking, too delicate yet. So if you prone them early enough, the hemodynamic consequences I've found anecdotally aren't as bad as it may seem. With that said, if you wait, right, so generally our approach is, you have volemia, generally they're on vasopressors, start diuresing them. If they're intravascularly depleted, that coupled with high mean airway pressures, right, the high PEEP, the high intrathoracic pressure that we know, anytime you have high intrathoracic pressure, your preload is reduced. Okay, so when you're moving these patients, if they cough, if they buck, anything that changes their preload, when you move them from supine to reverse Trendelenburg, and all of a sudden the volume pools in the legs and you lose your preload, absolutely. Before you even turn them, even if you move them into reverse Trendelenburg, they could go into cardiac arrest because these patients are so preload dependent. We've already altered their preload. So any one change could tip them over hemodynamically. So if you are concerned that they are on max pressors, anytime you look at them, that they drop their pressure, anytime you turn their head, you move their arm, they drop their pressure, I would strongly recommend not proning a patient. So anybody who's hemodynamically labile, I would consider that at least a relative, if not an absolute, definitely relative contraindication. There are other instances. Somebody might have a gigantic abdomen. You might not be able to prone them because the abdomen might not allow them to lay sort of flat on their chest. So there may be other more real sort of mechanistic ways of not being able to prone somebody safely, that if you just look at a picture of somebody who's prone and you apply your tenets of surgical sort of protection of pressure ulcers in the OR, the same tenets would be true for somebody who would remain prone for 16 hours. And finally, the dreaded complication of the breathing tube falling out. Generally, you might imagine these patients who with severe ARDS don't do well if they needed a breathing tube, wouldn't do well if the breathing tube fell out. Because the mean airway pressures are so high, sometimes as high as 30 or 40, then actually, if the ET tube is not secure, sometimes the vent can actually, ironically, push it out anytime you move them and turn them upside down because the mean airway pressures are so high. If they're inadequately paralyzed or not paralyzed at all, they could cough and bucket out. But if it falls out and they're prone, then it's a very dangerous and morbid condition. You have to flip them supine again. And if does very complex maneuver proning these patients, by the time you get them supine, they probably will be in cardiac arrest. And not only do you have to put the breathing tube back in, but you also have to initiate ACLS in somebody who's profoundly hypoxic. The final thing you want to consider is lines, especially if they have a pulmonary artery catheter. Anytime you move a patient with a pulmonary artery catheter, then that could cause arrhythmia. It could displace any lines that you have. Obviously, they have lines for reasons. So all of these things I've listed are all the potentials of complications of things that can happen while proning a patient. So consider those and have a low threshold to just say my patient is not a candidate for pronation.
And can you talk a little bit just how to actually prone the patient and for the duration that you do it and all that?
I can. I feel a picture is worth 1,000 words. The New England Journal of Medicine in 2013 published a paper that's publicly accessible that gives a 5-minute video on how to prone an intubated patient. It is publicly available and generally accepted as an academic publication. So, those who don't have an imagination based on my verbal experience, then there is a video made available by New England Journal of Medicine.
Excellent.
To watch it. But generally speaking, you need an operator to be at the airway, at the head. You need 2 people to be able to physically manipulate the body to flip it over, and it's usually a 4-person job at minimum, somebody to watch the lines and somebody to direct. But generally speaking, we all know how to move a patient over from the OR table to the bed. It's sort of like that. You move them over to the edge of the bed, and in a very concerted and controlled technique, you flip the patient from their back to their stomach and you pad their face. You generally turn the head with the breathing tube away from the ventilator, but all of this has to be predetermined based on the room that you're in, the ventilator circuit that you have, the central lines and the extensions that you have. But it's a very precise and coordinated technique. It is by no means intuitive and needs to be. We actually, 2 weeks ago, we created a pronation team, which generally were our neuroanesthesiologists who are very facile with proning patients in conjunction with our medical ICU nurses. And they have spent the last 2 weeks actually running simulations and training each core of ICU nurses in different ICUs how to do this safely. It is nothing that you can just walk into the room and think that you're able to do safely. You need to train, you need to simulate, and then you need to execute.
So have you had any experience with some of the specific medical therapies geared towards coronavirus, specifically immunosuppressant and the anti-inflammatory medications or hydroxychloroquine, et cetera, et cetera?
I have, by virtue of the multidisciplinary approach that we use in our severe COVID ARDS patients. I personally, as an intensivist, don't advocate any one of these per se, because at the moment it's not really proven to help. With that said, based on the mechanisms of the pathology and the body's response to this infection, a lot of antiretroviral therapies, antiviral therapies, and other interesting medications such as chloroquine, the mechanisms make sense. And it's worth considering the application to this disease because this disease has such a highly mortal phenotype. Some reviews or some retrospective analysis of the severe COVID-19 ARDS has a mortality rates of 49% or even higher. So in that case, I'm willing in these severe ARDS patients to entertain any treatment that's worth considering as long as we study it in a systematic way. Our infectious disease doctors in my institution are the one who are sort of coordinating those efforts to deem, just because the criteria for consideration of these medical therapies is a rapidly changing situation. The criteria for administration of empiric therapies such as chloroquine, remdesivir, ritonavir, among other virs, and anything else that might come up changes on a daily basis. So we leave a team of specialized folks to call the shots on that. And I personally, if they say my patient is a candidate for it, I won't disagree unless my patient has a known issue. So the ones that are most sort of readily talked about at the moment, and the ones sort of worth discussing initially would be chloroquine or hydroxychloroquine, Plaquenil, all these names that we use. But in my institution, and most of my patients are given chloroquine at the presentation of their severe presentation of ARDS. And that's just based on the treatment pathway that we've decided. We are systematically studying it. If it appears that chloroquine has no benefit when we look at the data, then I'm sure that we will stop it. But we've accepted the fact that it's at least worth trying. So I believe it's safe to say most of my patients have been on chloroquine. And as well as the ID team typically has been trying to give these patients azithromycin based on the studies that have been put out at this point. Again, they're not necessarily prospective and systematic, rigorous trials, but the risk of giving azithromycin is empirically is acceptable, in my opinion, if deemed by my ID colleagues to be true. We say this because, and we sort of rationalize this because these patients are so ill. As the disease process progresses, I have to say that when a patient gets intubated, the average time to extubation is roughly 10 to 12 days. We all know the longer somebody stays intubated, the more at risk they are of developing a secondary pneumonia, or what we say, a superimposed bacterial infection. They have indwelling central lines. So the odds of them needing an antibiotic on top of that are not low. So whether you give azithromycin early up front versus starting Zosyn later on if they have another fever, we do both of those things. We take it on a case-by-case basis. Nothing has been rigorously tested. I just generally tell myself every day and my team is to do something smart and be systematic about it. So right now, the medical therapies that we are utilizing that I've seen generally are chloroquine plus minus azithromycin. And when they are able to sort of enroll into the current studies for remdesivir, and right now my understanding of enrollment criteria is being on a ventilator with no vasopressors and no evidence of liver or kidney failure, then we do try to enroll them in the remdesivir sort of treatment as well. Others are rapidly emerging, and I encourage us to all consider empiric administration of them. But with that said, right now, my understanding and my practice is the best treatment for this is really just supportive, aptly applied critical care medicine. As long as we follow these medical therapies, one day we'll see if any of these have a profound effect on the mortality and morbidity of the severe phenotype. I'll tell you, I can give you guys one more brief snippet on chloroquine, actually.
Sure, okay.
Just as some added insight for chloroquine, generally speaking, I think it's a fairly innocuous drug. It does have the anecdotal concern, a real concern of potential QT prolongation. I've spoken with some very smart cardiologists and cardiac intensivists who I've known, and they generally say it's nothing really to worry about. With that said, the older these folks are, and some people with viral myocarditis or dilated cardiomyopathy, if they already have a prolonged QT, and I notice that the QT is prolonging or they actually have some arrhythmias, I may actually consider the utility of chloroquine or other agents that are known to alter QT, because I have seen a lot of arrhythmias. And these arrhythmias themselves can actually portend poorly and or cause mortality. So I haven't had to do it yet, but I do watch the QT interval when people are on chloroquine. And because we're using it so much now, we may actually see it as a rare but known complication.
Speaking of other drugs, What are the agents that you're using to sedate these patients and the neuroleptic agents you're using? And I know there's some concerns about shortages that are happening that aren't really discussed as much in the media. So what do we have to keep in mind when we're using these drugs?
Yes, so keep in mind the tenet of just being eminently adaptable. I am an anesthesiologist by my primary training, so sedation I love. It's my wheelhouse. So my initial go-to is as a very dense sedative agent that delivers great amnesia is good old propofol. And I try to use propofol initially. I really try to keep my doses protected because I really aim to use a sedative, either propofol or benzodiazepines as sedatives. Ativan, Versed, any other benzodiazepine. I use propofol or benzodiazepines for amnesia and amnesia alone. The goal for these patients should be vent synchrony. We don't want these patients, while they're so sick, to participate in their own care. We really don't want them to move too much because every time they move, as we've discussed, they can be hemodynamically labile, and we really don't want them to participate in their own ventilation. So we call that deep sedation, but I'm careful to say that. I don't mean high dose propofol and I don't mean high dose Ativan. I personally use low dose or moderate dose propofol at the beginning, and I use other agents. I advocate a multimodal approach. So moderate dose propofol and moderate dose narcotics. I advocate for using narcotics early. There definitely are risks, but narcotics plus propofol are an excellent synergistic combination of amnesia, sedation for serenity, and akinesis, not moving, not participating with the ventilator. So, a bolus or two of Dilaudid, a milligram at a time, maybe load them with 2 milligrams and start them on a half a milligram an hour, plus 40 mics per kg per minute of propofol is pretty much my go-to initial starting point. And then I see how the patient interacts. We all know that propofol can cause hypotension if they're in profound shock and or they're in liver failure. I have a low threshold to switch to Ativan or Versed. For amnesia, I maintain the narcotics. And if I have to go beyond that, I consider adding another adjunct such as ketamine. I don't really consider Precedex in the initial phase. I'm considering using Precedex in the end phase as I'm weaning. Precedex, in my opinion, is a little too light to be useful, and really the side effects of Precedex might just be too difficult to deconvolute in the initial phase. So propofol with aptly applied and at least moderate doses of narcotics. And if propofol is not an option or a shortage, then low threshold to transition to Ativan, Versed, or whatever benzodiazepine you have available.
Okay, so one of the things that we're seeing in these patients is the high incidence of renal failure. And, often with ARDS patients, at least, the idea is to run the patient dry and diurese them. But in patients with such high PEEP, you're reducing the preload, and they may need to have some volume to make up for that. So what's your recommendation as far as the fluid management of these patients?
Yes, as we've just discovered, and that's a great question. And I think you framed it as succinctly as you can. And even in that framing of the question, obviously the mechanisms and causes of renal failure can be numerous and very complex to know what is the tail and what is the dog. So my approach to the fluid management of these patients, the frequency of renal failure in these patients really has a lot to do with how you define renal failure. I see oliguria in pretty much every one of these patients. I also see their creatinine take a hit. I see their creatinine go up and BUN go up. Typically, before this, when I saw somebody who had worsening oliguria and an increasing creatinine and BUN, I would call that acute kidney insufficiency and potentially even end stage requiring dialysis. And a lot of the data would support that. And some of the data before this would even support putting them on early CVVHD if they're hemodynamically unstable, or early HD, or at least it would support saying if you put them on early HD, you wouldn't take away the ability of their kidneys to recover. With that said, I think we need to be mindful of what we're actually talking about renal failure. I see a lot of renal injury because I agree the approach to these patients, their fluid management needs to be precise. So there's a trial published in 2006 from New England Journal of Medicine that sort of started the conversation about how to manage fluids and severe ARDS. The fun acronym of FACT, F-A-C-T-T, talks about conservative versus liberal administration of fluids in these patients. It's helpful to know before they enrolled in this study, patients were fluid resuscitated before enrollment of this study. The average amount of fluids they got is somewhere around 2 liters-ish. So they're fluid resuscitated before they got enrolled. And then the conservative arm aimed for euvolemia between 48 hours and 7 days versus liberal, which is a net positive fluid balance up to 7 days. And it was found that the conservative group, the euvolemic group, had less days on a ventilator and had less lung injury, as they defined it in their paper, but it had no change in mortality at 60 days. So traditionally, we know ARDS is a problem with alveolar infiltrates and pulmonary edema. We as clinicians are reticent to give fluids to these people, and I as well am. But I advocate strongly for goal-directed fluid management, whatever your goals are. If they are fluid responsive, consider giving your patient fluid if there's signs of shock, because if they don't already have kidney problems, then they will. You will hyperperfuse the kidneys, and you could precipitate an acute kidney injury and maybe even pushing them to renal failure. The true incidence of dialysis-dependent acute kidney injury, in my experience, is actually really low. And right now, these COVID patients, I'm saving true dialysis for acidemia and hyperkalemia. Granted, the acidemia can be overcome with bicarb, but when you have acidemia in a patient who you can't ventilate, then the bicarb itself could actually be an issue, especially people who were already utilizing permissive hypercapnia to help their lungs. So I need the pH to be above 7.5. I'm willing to dialyze for that. And I need the potassium to be normal because these patients are exquisitely sensitive to arrhythmias, and there's a lot of cardiac arrest in the middle to tail end of this. So I think we should just get back to being precise. I, as an intensivist, have been giving CVVHD to a lot of my patients up to this point because I've had the CVVHD machines, and a lot of the science is sort of recommended it's not as bad as we used to think. But in this case, I'm much more precise. It's another line. The line could clot. There's problems with CVVHD, and they probably don't need it to run them euvolemic. I'm starting to question that FACT trial. I would love to aim for euvolemia, but if my patient is oliguric despite massive amounts of Bumex or Lasix, and they continue to be net positive by a day, or like a liter a day in the first week, I'm relaxing my thought about whether I'm actually not considering putting them on dialysis just to maintain euvolemia anymore. I think that trial is good as a starting point, but as long as you're not getting too far off the reservation in terms of your fluid balance, I think that the risk of putting them on CVVHD for fluid alone might outweigh the benefit.
Speaking of dialysis machines and clotting and VTE in general, I've heard reports as high as a 20% incidence of venous thromboembolism in these patients, and anecdotally, some of our ICU attendings have been talking about the CVVH lines clotting more frequently than they've normally seen. Some centers are putting these patients on essentially therapeutic anticoagulation. Do you have any words of advice to us as to how we should manage anticoagulation for these patients? We're hearing a lot about high D-dimers. Generally, we don't really, I generally ignore the D-dimer in a normal scenario, but high D-dimer in conjunction with all this clotting, should we be anticoagulating these patients?
Excellent question. I, as well, have noticed the same thing. Now, I have to caution myself. I was a student, and I was a medical student for 8 years getting my MD PhD, and I had the benefit of hearing some talks from Dr. Elias Zerhouni, who was the head of NIH from 2002 to 2008. And he drove into his audience's head. He had this saying that said, the plural of anecdotal is not data. With that said, we'll never know in the future what this phenotype really will end up being. After we're done treating them and the dust settles, all of our studies will eventually say whether or not the D-dimer of 1,000 meant they were hypercoagulable or not. But I agree. Clinically, these patients seem to me to be hypercoagulable. So I think it's safe to assume, until proven otherwise, they are. It's safe to assume that even if they don't have any of their predisposing risk factors, the young, healthy 30-year-old in front of your face definitely needs to be on aggressive prophylaxis. And if they show any sign of clinical thrombophilia, I would have a low threshold to actually therapeutically anticoagulate them. Because up until this point, knock on wood, I haven't seen any of these patients bleed on anticoagulation. Of course, they're going to bring comorbidities to the table. If they have a history of bleeding, if their HAS-bled score is high, of course, we don't use HAS-bled for this phenotype. But if their history of bleeding is high, don't do it. But all things being equal, if they're otherwise healthy, I generally look for any reason to anticoagulate them if they're at all thrombophilic clinically, because I've noticed the same thing. Hopefully the data will show true. At the moment, the current state of rigorously supported data doesn't support any one pattern, any one D-dimer plus CRP plus this means you should put them on 1 mg per kg of Lovenox a day versus prophylactic Lovenox. In general, our experience is that we are trying to use Lovenox more than heparin. We found Lovenox is much more reliable in terms of therapeusis, but also just pragmatically. Running a heparin drip, drawing PTTs every 6 hours takes a lot of PPE. By giving somebody a single dose of Lovenox a day or 2 doses of Lovenox, delivers therapeusis in terms of your anticoagulation, and B, requires the nurse to go into the room twice less daily. And we really have to be pragmatic about our treatment modalities. So that's really what we're going for now. Hopefully later on, we're initiating some studies right now to see if there's any other fun modalities that aren't really FDA approved or known to test for or prove hypercoagulability. But my own personal passion is point of care viscoelastic testing. Obviously, they're not FDA approved for this, but we're all trying to see if we can find some magical pattern to help we as clinicians predict who is thrombophilic. And the best prevention of developing a DVT and PE, the best treatment of a DVT and PE is preventing it. So if we can come up with good predictive models and knowing who we should anticoagulate beforehand, then that would be ideal. But there's no data to help guide that aside from just a smart and sort of vigilant physician at the bedside.
Jim, what are some of the deviations that you've noted from our traditional ICU strategies that you can maybe give to our listeners outside? It's like not getting daily chest X-rays. We're keeping the pumps out of the room so that the nurses don't have to use up PPE when they want to change rates. What are some of the new strategies you guys have adopted for that?
That is an excellent question. I think that I have to take what I generally have hammered home as an intensivist rounding daily in the ICU. Good tenets of critical care medicine on an intubated patient, we really have to rethink those right now. I can tell you we are not getting daily x-rays on our patients. I know that these patients are going to have ground glass opacities well after they get discharged. A daily x-ray is, again, I critically think about anything I order that causes patients to go into the room. So no more daily x-rays, no more daily EKGs, no more daily spontaneous breathing trials in the acute phase. Do not do it. Do not wean the sedation. Don't give them an SBT while they're in severe ARDS. They will de-recruit. They'll go down like a freight train. You'll have to take hours to re-recruit them. And again, that before this point, that would be heresy. But there is a subgroup of people we don't do SBTs on, and it's severe ARDS. When your entire ICU has severe ARDS, you're not going to do one daily SBT. Take that, looking at other organ systems, we are very aggressive in terms of our nutrition, more so than usual. So we start empiric nutrition whenever we can. We've developed sort of admission bundles so as to coordinate whenever the physician goes in the room to place the lines, we would do the transthoracic echo. We're really mindful of what we do and when we do it. No more do we really try to consolidate our labs. As you mentioned, we try to keep our infusion pumps outside the room if we have enough extension tubing. Our typical ICU looks completely different than the way it did before. The pumps are out of the room. The ventilator machine, the screen is out of the room. We look at these patients from the window, and we designate one member of the team to go in to do the physical exam, and we reevaluate the patient only when needed, only when they're clinically changing. Did I hit all of the ones that we've noticed? Oh, actually, there's a couple more. So I have had to rethink typically other tests or diagnostic things that I do to these patients, such as bronchoscopy or sending my patients for a CAT scan, things we routinely do in the surgical ICU. But we have to be mindful that anytime we do a bronch on our patients, we have to disconnect the circuit, and they will de-recruit. And when you de-recruit, it takes hours for them to come up. Also, when you do a bronchoscopy, you aerosolize a bunch of COVID-19. So you put anybody in the room who is not properly fitted with PPE, you expose everybody in the room. So that's something that we really try to minimize. So I'm only bronching patients after they have an acute mucus plug that's recalcitrant to aggressive inline suctioning, and going from there. So I've completely rethought my typical approach to my critically ill patient.
So speaking of things we may do a little bit differently, can you talk about CPR in these patients? Unfortunately, we are seeing some patients have cardiac arrests. Not many of them are salvageable. But what's the approach to CPR in a patient with COVID?
It's a really good question and an active area of hot debate. So without getting into it, what I tell members of my team, because I often oversee a very large team and, maybe as many as 40 COVID patients, but there's a lot of practitioners below me who may be the first responders to somebody who goes into cardiac arrest. I remind them of the laws of this seminal book written by Samuel Shem in the 70s, the laws of the house of God. And I think the sixth law was the first procedure to do during cardiac arrest is to take your own pulse. That is to say, is to be deliberate about your movements during cardiac arrest. Be systematic the way we always do. I tell my folks, don't expose yourself unnecessarily to any undue risk. If a patient who has COVID-19 and is isolated in the ICU room and nobody's in there when they go into cardiac arrest, it is very dangerous to rush in there without PPE. You're unnecessarily exposing yourself. When you do chest compressions, you have risk of dislodging the breathing tube. You have risk of disconnecting them from the vent. And if you aren't wearing the active PPE, then you will get exposed and potentially come down with this disease. And the last thing we want to do is have healthcare practitioners getting needlessly exposed. So if somebody goes into cardiac arrest, move deliberately, don your PPE, go in, initiate ACLS as is typical. Look at the rhythm, figure out what caused it. Ask yourselves if there is any reversible causes that you can reverse. And if there aren't, and they're still in cardiac arrest, then do what we would normally do as physicians. And at some point, we have to call a cardiac arrest.
Are we bagging these patients, or are we leaving them hooked up to the ventilator?
Excellent question. So initially, we try to leave them hooked up to a ventilator. If you have an extra set of hands, it is possible to bag the patient with a viral filter that you can put on a BVM. But anytime you disconnect the patient, you expose the whole room to aerosolization. So it is possible to bag a patient, and I think you just have to be smart about it. If you think it was a respiratory arrest, then that's true. But you're right. If you're doing chest compressions, you leave them on a ventilator. If it wasn't a respiratory arrest, quickly it will become respiratory acidosis and unsurvivable. So what we know is that people who do go into cardiac arrest, ACLS typically is not as effective. COVID-19 patients who go into cardiac arrest typically die. With that said, I'm against blanket statements of not doing any ACLS because in a young, healthy 30-year-old, I've also seen a mucus plug try to kill him. And if I get in there and I bag him and I push the mucus plug down, I can get him back and they can survive. So I advocate approaching ACLS on a case-by-case basis, but being smart and being mindful not to expose yourselves. The final thing to mention is what happens if you have a prone patient who goes into ACLS. Again, things you never thought you would ever have to consider. But usually, ACLS takes some time for the dust to settle. As you might imagine, it takes a long time to flip somebody prone and flip somebody supine. And if you wait that long to do chest compressions, forget about it. They will not survive. So if you go in and you think there might be a modifiable cause, you could consider giving your epinephrine and doing a round of chest compressions while prone. You just put your hands in between the scapulae, somewhere mid between the scapulae, and compress the way you normally would. And you can actually circulate whatever medication you just give and at least give them a round. If they come back and you think there's something modifiable, you have to work to try to flip them supine. Anyway, ACLS is always a melee. I don't advocate for the blanket administration of not giving these patients ACLS. I accept the fact that when these patients do go into cardiac arrest, most of them do die, but emphasis on the fact most of them. Your prototypical healthy 30-year-old might just have mucus plugged. And if you don't even take the chance to give it a shot, in that case, you can take 2 minutes to put on your PPE. If it's a mucus plug, he might actually survive, he or she.
So that would lead to sort of a next question is, what has been your strategies with goals of care discussion? And the fact that these can't be had in person with the family at the bedside because of our current visitation restrictions.
Yes, it's a whole new world. We're all getting better at that. So in my opinion, anybody who's admitted or comes into the ED for COVID-19, we should be starting to have that goals of care discussion upon admission to the ED. Of course, we've been saying that for years, right? We as physicians, anytime you get admitted to the hospital, you should have a goals of care discussion. But my discussion is a real discussion. I really try not to sugarcoat the phenotype of this disease. I sort of quote some numbers when I can. Of course, I advocate not making decisions for your own individual family member based on worldwide statistics. But with that said, I try to drive the fact home that this is a very serious condition, and we are going to do everything we can. But now is the time to start thinking about if all of our maximum therapies aren't working, what is it that you and your family member would best like to be done in that instance? Sometimes that's not intubating them. Sometimes we have people who are at DNI, and that's when we've started to accept the fact we might have to put some of these people on non-invasive positive pressure ventilation, see if we can get them through, because intubation would not be what they would want at end of life. Otherwise, the young, healthy 30-year-old who's intubated and who's not doing well in your ICU, and you've pulled out all your tricks, what do you do then? A lot of hospitals have limited visitation to family members only at end-of-life situations, and usually limited to one. So I really try, and I know it's sort of a tough discussion to have. It's delicate, but when given the opportunity, I try to understand the family network early on to decide who would want to be around and how they could be around, because usually it can't be physical anymore. So I usually try to see what their technological abilities are, if they have the ability to be present via a smartphone device or something like that. We're still developing this as we go. But to get to your question, I'm trying to entertain all discussions blanketly to all patients who get admitted to the ICU for this, understanding that the current data shows that there's at least a 49% mortality of these patients. So we have to accept the fact that more people will die than we like at the moment until we get better at this. So early discussions about end-of-life care, and often. And if somebody is truly dying, it seems to have a huge effect if we can at least make efforts to have them be present remotely via video, if that's their wishes, or at least via voice.
In New York City here, we're about to enter the peak of this pandemic in the next couple of weeks. What are some of the things you're hopeful for to happen in the next couple of weeks? And do you have any final words of wisdom for our audience, to something to leave them with?
I'll tell you, it's daunting what we have set forth in the future, in the next days to come here in New York. We're still ramping up. We're still admitting. We're able to stay one step of the curve, thankfully, at my institution. And it's been just inspirational to get to show up to work and work with such a dedicated and hugely multidisciplinary team. So my first wish is something we're already getting used to coming together and working great as a gigantic team moving forward. The advice I would give people in New York and elsewhere who see the wave coming, the wave is real, and you don't know if in your institution or in your community it will hit or if it won't hit. But if it does, I highly recommend thinking about it and planning for it now. It would just be a tragedy. It's a tragedy right now if a hospital's full to have a simple trauma that otherwise would be survivable in normal circumstances, but if not offered the current medical therapies because your hospital is full, it's a tragedy when you have simple things like a heart attack killing people we could otherwise save. So I really hope that people outside of New York and the world really espouse this and are actively starting to make plans to help treat the patients who get sick outside of COVID-19 the way we've been able to. And I'm just continue to take it day by day. I tell my team every time I work with them is that the treatment of these patients changes. The resources that we normally have are at liberty of cutting short or disappearing on a moment's notice. I can have one thing one day and one thing the next. The bottom line is we need creative solutions, and we need smart people at the bedside, being smart, doing smart things, and being systematic about it. And if you think something's working, let's talk about it, and let's think about studying it and doing what we can. But so far, so good. Keep up the hard work. And don't hesitate to think outside the box and coordinate with your peers. So far, we've come so far in ways that I can't ever have imagined, and we have a long way to go. So I think we're going to develop a lot more, ideal and interesting approaches that are successful to this.
Well, that was fantastic, Jim. Really, thank you very much for that. And I think our listeners will find it very useful. We'll be including a bunch of stuff in the show notes, especially that link to the New England Journal of Medicine proning video that you mentioned, and anything else you think may be appropriate. But we really appreciate you taking the time to discuss this with us.
Thanks. Thank you very much. I'll leave you with my parting words that I tell my fellows and now my residents and really anybody who works with me. And these are the words that got me through my fellowship and my training up to this point. And that I really had to learn quickly that no matter how bad things seem today, that I should be thankful that they're not worse, because they can quickly get worse in a heartbeat.
Yeah, thank you very much, Dr. LittleJohn. I hope that all the listeners, whether they're vascular surgeons or other types of surgeons or any physicians, can use this as a primer to help them as they enter the critical care world, taking care of these patients. I'm honestly inspired by everyone around me. All of my co-residents and attendings have been galvanized into action. And, I went into general surgery and vascular because I like taking care of sick patients, and it's been a privilege to be able to be a part of this. So I want to thank you for helping us educate everybody, and I hope somebody takes something away from this. Views and opinions expressed in this podcast are those only of Dr. LittleJohn and do not necessarily reflect the official policy or position of any specific agency or institution.